Okay, like I said, welcome to Let's Talk Dental, a BioLays webinar series. We're very excited to welcome Lynn Atkinson as our speaker. The lecture this evening is called How to Implement Diode Lasers into Guided Biofilm Therapy, an introduction to the science and protocols. And also wanted to say we're very grateful to our co-sponsor for this webinar, EMS Guided Biofilm Therapy. We are hosting tonight's webinar on the Zoom platform as always, and welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen. We will wrap up tonight's session just with a few minutes to address audience questions with Lynn, so feel free to post your questions during the lecture. You'll see there's a chat area and then there's also a Q&A area. I would just ask that you put your questions in the Q&A area. At the conclusion of the lecture, I will provide information about BioLays education CE process, along with additional web resources you can access to continue your learning journey in laser dentistry, including an upcoming 3-part webinar series focused on optimizing practice growth by leveraging laser technologies. So stay tuned for more information on that. Also wanted to say tonight's webinar is being recorded and will be posted to our webinar library in the coming days at education.biolays.com. Lynn Atkinson has been a registered dental hygienist for 35 years. She graduated from Cypress College in California with a degree in dental hygiene and has been fortunate enough to be a part of several dental teams that have incorporated state-of-the-art technology. For the past several years, Lynn has been a speaker at numerous conferences across the nation, speaking on lasers, guided biofilm therapy, perio implant care diagnosis, comprehensive care, verbiage, and documentation. A lot of those topics you'll see tonight in her presentation. She lectures locally in addition to her hands-on courses, has authored several published articles, and has been a guest speaker on industry audio media platforms enjoyed nationwide. Lynn is a speaker and Swiss Dental Academy trainer for US EMS Guided Biofilm Therapy and a speaker and educator for BioLays. She serves on the board of directors at the Academy of Laser Dentistry as auxiliary chair, a member of the ALD Speakers Bureau, Education, Conference, and Testing Committees. Lynn is a standard level course trainer for the Academy of Laser Dentistry and is the honored recipient of the ALD 2022 Leon Goldman Clinical Excellence Award. So Lynn, thanks so much for joining us this evening. We're super excited to have you and to learn more about these two technologies. So I will hand it over to you.
Thank you, Joe. I appreciate it. Welcome, everybody. Joe just did a nice job of introducing me. I always start out with my family because family is always first. And even though they get neglected sometimes with work, but this is why I do what I do. This is why I'll be working until I'm 95. And I love my big little family. My other family is Academy of Laser Dentistry, as Joe mentioned, and we are having our conference this year in September in Phoenix. I would love for you all to join us. I am a clinical clinician and an educator, so I work 3 days a week. Right now, I've just cut down to 3 days a week, and I also go out and educate. So I'm also an SDA trainer, which is Swiss Dental Academy trainer for the guided biofilm therapy. And I not only train in it, but that's what I'm doing all day long, every day in my clinical skills. I do have some disclosures that I'm a KOL for several different companies, as well as a speaker and educator for BioLays and for Academy of Laser Dentistry, as well as EMS, Guided Biofilm Therapy. The other disclosures are the content and recommendations and opinions and views expressed in this course are solely by me, the presenter, and I will be receiving an educational honorarium through BioLays. And the photos and videos have been given permission by my patients for educational and training use. So, just to introduce you all to periodontal disease is a chronic multifactorial inflammatory disease associated with dysbiotic biofilms and are characterized by progressive destruction of tooth supporting structures. Microbial biofilm will lead to dysbiosis between the host immune inflammatory responses and may progress to gingivitis and periodontal disease in susceptible individuals. Removal of dental biofilm is essential to prevent inflammation and periodontal disease. The combination of laser therapy and guided biofilm therapy play a significant role in effectively and efficiently disrupting that dental biofilm. So nothing has rocked my world enough as much as guided biofilm therapy has. I've been using it for approximately the last 2 years, and the lasers for about 28 years now. So I've been in the business for a very long time. I love it, but nothing has worked so well for me and my periodontal patients as guided biofilm therapy and lasers. And it seems like whenever I go out to offices that are open or using lasers, and I'll do some training or education on lasers, they're always open to the guided biofilm therapy, and vice versa. If I'm doing guided biofilm therapy, they're always interested in the laser technology. So I really feel like they go hand in hand, and that's what I'd like to just kind of bring home today. So our objectives, we're going to discuss the role of biofilm in gingivitis and periodontal disease and analyze the value of using a combined approach of lasers and guided biofilm therapy. We're going to determine when adjunctive laser therapy is implemented to achieve optimal clinical endpoints and understand the ultimate goal of effective therapies in biofilm removal. We're going to review the advantages of using less invasive approaches for optimum patient results. Let's talk about where disease begins. Hippocrates said that all diseases begin in the gut, but all diseases in the gut begin with the oral cavity. So they have to get to the gut. So I feel like it all starts with the oral cavity. In dysbiosis of the gut, it's associated with changes in the gut permeability, hence we call it leaky gut, leading to invasion of bacteria into the mucosal lining. It's no different in the mouth, and gingival bacteria invasions and persistence have been described as critical events in the pathogenesis of periodontitis or leaky gums. So it's the same thing in the mouth that it is in the gut. Biofilm, what is it? It's a community of bacterial cells that attach to a surface. So it can be found all over. It can be found in rivers and oceans and drains and water, in teeth, gum tissue, restorations. And it plays a crucial role in periodontal and perio implant diseases. Biofilm causes destruction of supporting tissues of the tooth or implant. And it's highly complex microorganisms. There's over 250 species of microbes in the oral cavity. Biofilm has an extracellular matrix and microorganisms, and then it also has this EPS, which is extracellular polymeric substances. It's like a goo on the outside of these organisms, and it holds everything together. And these it also helps protect these bacteria and this matrix. The polysaccharides, there's DNA, there's lipids, there's proteins. All of this is encompassed in that biofilm. So what are the stages of biofilm development? Well, first it has to adhere to something. So it can be a tooth structure, it can be root structure, it can be the gum tissue, it can be the sulcus. Once they adhere to those areas, then they multiply and they get this accumulation and this maturization. So when the bacteria first come into play, it can happen within a few seconds. So the patient comes in, has their hygiene visit, and within seconds, those cells start to form. Those first colonizers become irreversibly attached in seconds or in minutes. And the growth and cell division happens within hours or days, depending on the host. And the production of that EPS and formation of those water channels, or the formation of the EPS, can happen also within hours or days, again, depending on the host. And the attachment of secondary colonizers and dispersion of the microbes into the new sites can happen in days or months. So all of these bacteria can adhere to these areas, but sometimes they aren't really necessarily pathogenic. They live in this symbiotic relationship. That acquired pellicle, that acquired enamel pellicle, contains proteins and also bacteria. These early colonizers, the Streptococcus, the Actinomyces, the aggregator bacter, and Actinomycetes are these green complex. So the yellow and the green complex are the gram-negative anaerobes that attach to soft tissue cells. So they can live in that environment. As they grow, as they become more anaerobic, these late colonizers form, and these are the red complex colonizers, and they are really pathogenic. They can cause disruption, they can cause inflammation, bacterial invasion into the gum tissue, bone loss, and tooth loss. So the microbiome in the oral cavity is highly complex polymicrobial biofilm communities. The microbiome is this community of biofilms, but they can live in a symbiotic relationship. Microbiome is the community of microorganisms that can usually be found living together in a given habitat. So if you have the tongue microbiome, you can have microbiome in the gut, you can have microbiome in the oral cavity, you can have a microbiome in specific areas in the oral cavity. And the combined genetic material of the microorganisms in a particular environment are that microbiome. So microbial colonization or transmission can be affected by either genetics. You can have maternal transmission. So we're always, with genetics, we're always concerned about if they have these genes, maybe their family history of periodontal disease, family history of diabetes, family history of some kind of immune suppressant disease. And maternal transmission, you can get that from mother to baby, or to infant, or to newborn. And then dietary habits of the patients. What are they putting in the oral cavity, and their oral hygiene habits, obviously, any medications that they take. Medications can dry out the mouth. They can cause, acidic biofilm. And there are systemic factors that are involved as well. I'm going to go past that one. Challenges that we have with biofilm: there's environmental factors, there's local factors, and also systemic factors. All of these we're going to review right now. The environmental factors are the host diet or their dietary habits, the oral hygiene, their stress levels. I don't think we put enough pressure on enough emphasis on stress levels, because if the patient is more stressed than usual, then their body resistance is lowered and they can't fight against that inflammatory process. Just like if you're going to get sick, if you're going to be exposed to a virus, and you might be fine, but then when your body resistance is lowered. So I explain that a lot of times to the patient, or they think I'm a mind reader because I see their mouth is full of inflammation when maybe they were okay 3 months ago or 6 months ago. And I ask them if they are under more stress than usual, which is everybody nowadays. And that will affect how their body responds to that type of bacteria or that inflammation. If the patient smokes, there's an increase in chance of periodontal disease, in bone loss, dries out the mouth, certain bacteria. Medications that they can take, like I said, any medications can dry out the mouth. They can cause issues that way. Also salivary flow, again, xerostomia, masticatory forces, how is their occlusal forces, and exogenous microbes. This is just some patient information that I have for from AOSH. And AOSH is going to, they give out this information, and I print it out and I also give it out to the patients. Something like talking to your patients about biofilm and talking to them about giving them this, saying, you know, they're not the only ones. Nearly half of American adults have periodontitis and the most severe forms of periodontal disease. And then you can tell them there's 700 species of bacteria that can live in your mouth. And 11 of those pathogens are linked to oral and systemic diseases. So I also have a page that it shows how it's linked to all the systemic diseases, so that they can have that information, pass that on. So periodontal pathogens, certain periodontal pathogens can invade the periodontal tissues. I feel like this is really important as far as the periodontal pathogens invading that sulcus, because there's no other way to get to that bacteria. So I think with guided biofilm therapy, where we're trying to remove as much of that biofilm as we can in all the nooks and crannies and on the tissues, and then going in with a laser and actually having that get to that embedded bacteria and that biofilm, especially that embedded pathogenic bacteria. And P. gingivalis can penetrate oral epithelial cells. Again, really important, because we know that lasers can help us out with that, as well as the guided biofilm therapy. This part is really important because it encompasses everything that you have to do. It's not just that we use lasers. It's not just that we do guided biofilm therapy. It's not that we just do other adjunctive therapies. But if you're not getting to the core of the issue, the inflammatory issue, we need to be very comprehensive in our dental care. So not only your health history, taking blood pressure on every patient, asking them who their physician is, when their last physical was. This is super important, their last physical, because if they say, oh, it's been 10 years since I last had a physical, but I'm perfectly healthy, I don't take any medications, I haven't had any hospitalization or surgery, no allergies, and then they get in your chair and they have bleeding, inflammation, bone loss, well, then we might just send them back to their physician to collaborate with them. So any hospitalization or surgeries, any new diagnosis that they have, any medications that they're taking, and also any allergies. I'm real big on diagnostic radiographs. Make sure that you're taking vertical bite wings on your perio patients, that you're seeing the crest of the bone, that you're seeing furcations, that you can actually diagnose according to those x-rays. This is an example of non-diagnostic x-rays to your left. I couldn't even tell that there was implants there. And then I went ahead and took some vertical bite wings so that I can see the crest of the bone, as well as taking some periapicals in that area. This is just another example. If I get a horizontal bite wing, I had no idea that that's going on the mesial of number 3 there. And I can see more on the furcations and again, the crest of the bone. CBCT scans are really important. They help with a 3-dimensional view of what's going on. If you're just treating what's going on in the mouth by a 2-dimensional image and your periodontal evaluation, the CT scan will give you much more information as far as what's going on buccal and lingual, and also give you a lot of other information as far as the bone and other structures. So this is just a two-dimensional image, which, yes, if I look back, I would say, yeah, there's definitely an abscess there. But in a two-dimensional image, sometimes it can appear to look like the sinus. When we take a CT scan, you can see it clearly on the CT scan, and that tooth was extracted and has a beautiful abscess on the end of it. Digital scans are super important. Taking those digital scans are almost like taking photos and giving you an idea on what's going on, and you get the patient involved, and they can see tissues, they can see their occlusion. We can track recession, we can track gingival margins, all of that. I also do VoiceWorks by Florida Probe, because that really helps me in diagnosis and gives a graphic representation, not only for me, but for the patient to see what's going on periodontally. So I just kind of want to move past those. You can see that you can compare from one point before you did laser periodontal therapy till afterwards. You can track the progression of their percentages of bleeding points. What I also love about it is that you can do a risk assessment. So it'll pull from their age, from their bone loss, their bleeding points, and then you can also add in there any systemic factors, any family history of periodontal disease or diabetes, or if they're a smoker or if they've had periodontal surgery in the past. So then it all puts them into a risk score. So we know that, hey, this patient is at a high risk score. We really need to keep on top of that patient. And then you can also print this out for the patient, and they can have that information to also read to take home. And again, a comparison before and after laser periodontal therapy and guided biofilm therapy. This is some other brochures on an oral systemic link. We all know this oral systemic link, but our patients don't always know that our head is connected at the neck. They think that everything is separate, just what's going on in their mouth. So my gums bleed, they've always bled, that's just the way I am. But this really pulls everything home. So you can also give these to the patient. You can highlight maybe diseases that they have and how that is correlated. All right, disease progression and severity can be influenced by a patient's response to dental biofilm. So it's not just the dental biofilm that causes periodontal disease or that causes inflammation. It's actually the host's response. It's the patient's response, because we've all seen it. We've all seen that patient that comes in with a ton of stuff on their teeth. They've got biofilm, they have plaque, they have tartar, they have food, they have all kinds of stuff going on, but they don't have a lick of bone loss. They don't have inflammation. So it's the way that their body's responding to that. And some cases require more intensive control of dental biofilm and inflammation. So some people can, get along fine at coming in at a longer interval, and those other ones need to have this intensive control. So seeing them more frequently, going through some adjunctive therapies or laser periodontal therapy. And you have to use your clinical judgment for comprehensive treatment for individual needs for the patient. This is not just a cookie cutter protocols to do for the patient every time that you see them. It may be different each time that you see them, hence doing your periodontal evaluations every time. So the biofilm battle, what do we have in our treatment modalities to combat biofilm and inflammation? So we have our traditional methods of scaling and ultrasonics, scaling and replaning ultrasonics. We have antibiotic therapies. We can put antibiotic therapies topical or oral, subgingival irrigations, medicament delivery trays, desiccation gels and liquids. And all of these things you may have in your armamentarium, but some of these things you can't do every single time that you see them, or you maybe they don't work on one patient, they don't work on another patient. But all of these things are, some of them can be very effective, but I feel like guided biofilm therapy and the laser therapy, that's something that you can do consistently every single patient, every single time that you see them. You can do some kind of guided biofilm therapy or laser therapy, and those are the things that I'm going to share with you. Talk a little bit about lasers because you need to have the background of lasers. Laser stands for light amplification by stimulated emission of radiation. And there are several different lasers out there on the market. This is just a handful of them. Diode lasers are the most common lasers in the hygiene department, especially. They're small, they're portable, they're fairly reasonable to put in each operatory. And they're soft tissue lasers only. Other lasers in dentistry are your Nd:YAG laser, which is also a soft tissue laser. And then we have your erbium chromium YSGG. That is your water laser, the BioLase water laser, the erbium YAG. Those are both hard and soft tissue lasers, as well as your CO2 lasers, your CO2 laser that is a soft tissue laser, and then also your CO2 that's a hard and soft tissue laser. So let's go a little bit into the protocols, and then I'll show you some case studies. Protocols for doing GBT and lasers. So you have a patient that comes in for a periodontal maintenance, and you can either do laser bacterial reduction before the appointment, or you can do it post-procedural. I don't care which way you do it, just have it everyone doing it the same way within the office. Laser bacterial reduction will help reduce the bacterial flora in the pocket areas, in the gingival sulcus, as well as increase healing, reduce the pathogenic anaerobic bacteria, stimulate new healthy cells. And then we have procedures that we can do with laser periodontal therapy. Laser-assisted periodontal therapy is done with our non-surgical periodontal therapy. So when we're doing our scaling and root planing, that is different than doing laser bacterial reduction, and I will go over those procedures. We can have a prophy or a gingival therapy, your 43, 46, a debridement. They come in and they're, kind of riddled with deposits, and we need to do a full mouth debridement, which makes it really nice to do that with the airflow system, the guided biofilm therapy now. Your periodontal maintenance and your non-surgical periodontal therapy. So in a prophy appointment, we're going to review their health history. We're going to go over their blood pressure. We're going to do our oral cancer screening, all of our screenings that we're going to do in the beginning. And then you can do your laser bacterial reduction. Like I said, it can be performed either prior to any instrumentation. And the thought is that we're not going to cross-contaminate. It'll help reduce the bacteria and the aerosols that we produce. So you can do it before you do any instrumentation. Or you can do it at the end. You're going to go through and do your periodontal and risk assessment, your biofilm assessment and motivation, go through with your airflow. The biofilm assessment and motivation is when we disclose. So I'm disclosing every single patient now. And I love it. It helps guide me. That's the only thing that guides me to be able to remove all of the biofilm. And then also you can motivate your patient by telling them, showing them the type of bacteria that's in there, the type of biofilm, where it's hanging out. I don't like to tell the patient that this is where they're missing. That's not what disclosing is all about. It's showing them how they can be more effective and where the biofilm is lying in those areas that make it more difficult to remove. We do our airflow throughout the whole mouth, our PAs on if needed, and I'll go over those procedures. Hand scaling only if needed. I know everyone's out there thinking, I love my hand scaling, and I still have to hand scale. Now that I've become very proficient with the piezon and using my left and my rights and getting into all those areas, I very rarely, especially in my prophies and my perio maintenance, need to pick up a hand scaler. Then we can do laser bacterial reduction at the end of the appointment. Like I said, I do it that way. I've been doing that for 28 years. And my belief is that I want to get all the biofilm off of there and then go through at the very end and help stimulate new healthy cells, reduce that inflammation. It only takes about 5 minutes, and I have all that time to explain to the patient exactly why I'm doing it at that point. And then we can do our fluoride application, our hydroxyapatite, our nanohydroxyapatite applications, or any other adjunctive therapies. And like I said, that LBR can be performed before or after the appointment. So gingival therapy of 4346 is a patient that comes in with severe gingival inflammation without any bone loss. So this is not done prior to doing periodontal therapy. This is something that is done in the absence of any bone loss. You still see all that crestal bone, but you have severe inflammation, so that you want the patient to come back at another visit. We used to call it a prophy 1, a prophy 2, but now we've fought for this code, and we now have that code, and that's what should be used. We're going to do the same thing. We're going to do your health history, your laser bacterial reduction, your periodontal and risk assessment. I do that every time anyways. Your biofilm assessment, your airflow, your piezon. Most of the time in that gingival therapy, it's just a lot of biofilm. Maybe you're going to use a piezon in some of those localized areas, but most of that is just getting most of that biofilm off of there. And then same thing, you'd have them come back in about 3 to 4 weeks to do a reevaluation, a prophy at that appointment, and you would do your LBR at that appointment as well. Periodontal maintenance is, again, going to be a little bit different, but you're going to go through the same protocols of your assessments, your infection control, your assessments, your LBR, your periodontal and risk assessments. Please do those periodontal and risk assessments every time that they come in, especially if they're a periodontal maintenance. Biofilm assessment and motivation, airflow. The piezon is only used in localized areas, so you're always removing biofilm first and then going through and using your piezon only on hard deposits only. Hand scaling if needed, and then localized scaling and root planing in any localized areas. So we know with the code of 4910 that is the difference between that and a prophy, is that not only is it following up doing a periodontal therapy, but also we are going and doing some localized scaling and root planing or laser therapies in those localized areas that are not maintained. Periodontal maintenance is what it is. It says a maintenance. That means the patient is being maintained. So each and every time that you see them, you are required to go into any of those unmaintained areas and do treatment on those areas. And more adjunctive therapies or more treatment therapies may need to be done, or more diagnosis. Obviously, if they come in and they've got 7 areas that need this localized scaling and root planing, you need to kind of rethink what the patient needs to have done in their diagnosis for their next treatment. Localized LAPT in any areas that aren't maintained, and then you can do your fluoride application, your hydroxyapatite, and any other adjunctive therapies. Non-surgical periodontal therapy is your health history, your blood pressure, biofilm assessment. We're still going to go through the same routine. I'm still going to disclose. Sometimes if I do half the mouth or a quarter of the mouth or a section of the mouth, I'm going to disclose that section. But as they come in for their future appointments, and I've already treated, let's say, that right side, and I have examples of this, and then I'm treating the left side, then I'm going to I'm going to disclose the whole mouth. And it's amazing what you can see and what you can show your patient as far as how quickly that biofilm is starting to form on the side that we just maybe treated a week ago. But there's always a difference in one side and the other, and you can show that to your patient. You're going to go through with your airflow, your PAs which PS is perio slim, your perio slim left and rights. Your PI Max, which is a carbon and peak material that's used around implants, around crowns, around veneers, around dental surfaces, anywhere you can use that. And then hand scaling again, if needed. I've got I kind of left out the anesthetic. And then your laser assisted periodontal therapy. And then you can apply either vitamin E or any gels like things like Perioscience or Stella Life, things like that you can put on there to help that immune system. So let's talk a little bit about what LBR is. Laser bacterial reduction is painless, and this is verbiage that you can give to your patient, and it's added to their periodontal maintenance or their continued care appointments. It'll only take approximately 5 minutes. There's no anesthetic necessary, and this will reduce the bacteria in the diseased gums, stimulate new cell growth and healing of the tissues, and reduce bacteria in the aerosols that we produce. It's used to help prevent the start of inflammation and or help to prevent further periodontal breakdown. So when they're going through and they're coming in for their periodontal maintenance, the patients know that they're going to have this laser bacterial reduction each time they come in, because that's only going to help prevent further periodontal breakdown and prevent further inflammation. Even on your healthy patients will want to have that laser bacterial reduction done. It can be incorporated on all patients. So this is something that you can use for every single patient, every single time they come in. It's not accumulative as far as, you can't use laser too many times. It can be used as a preventative method, and it's used to maintain periodontal health. It targets anaerobic pathogenic bacteria. I know I put anaerobic twice, sorry about that. Anaerobic bacteria, most of this pathogenic anaerobic bacteria is pigmented. So the diode laser is only absorbed in dark pigmentation and hemoglobin. So any dark pigmented bacteria, the laser energy is going to be absorbed into that bacteria. It will also be absorbed into any of the bleeding, any of the inflammation, and it'll help stimulate new cell growth as well. It lowers the microbial count in the aerosols, and it assists in cell regeneration and healing of those tissues. This is what LBR looks like. You can use it on, somebody like this that has a lot of malalignment. So it's a really thin fiber. In LBR, you only need to get about maybe 0.5 to 1 millimeter. I get underneath about 1 millimeter, and it sprays that laser energy underneath the gum tissue until it hits its target. So you don't have to cover each and every surface when you're doing LBR. That's why you want to stay at that surface. It's a very deep setting. This is what laser bacterial reduction looks like. There we go. You just do short overlapping strokes. I try and keep it as parallel as I can. Again, only going about 1 millimeter underneath the gum tissue. This is not painful. They shouldn't feel heat. They shouldn't feel warmth. They shouldn't feel discomfort. If they do, I always say if the patients feel it, it's the clinician's fault, because this is something like, I like to look at it as photobiomodulation. We're just putting that laser energy and spreading it underneath the gum tissue. Always use your high volume evacuation. Even though this is not producing aerosols and it is not what we call an initiated tip, so it won't cause a plume, but just by chance if it does become pre-initiated. This is doing guided biofilm therapy and laser therapy on a maintenance patient, though. And it is very difficult to get around all those brackets and get around everything. So laser and GBT are a perfect combination to use for that. Also, laser-assisted periodontal therapy, it's not scaling and replaning. It's a procedure that's performed using local or topical anesthetic. And guided biofilm therapy is performed on the tooth and the root surface, removing all the deposits and embedded toxins. And then we treat it's treating the root surface, but then the laser then treats the gum tissue. So it selectively debrides that disease-infected tissues and removes any embedded bacteria underneath the gums and helps regenerate new healthy tissue. And due to the laser's ability, it kind of seals off those nerve endings, so they don't really have discomfort afterwards. But in laser-assisted periodontal therapy, you can see that coagulum kind of building up around the end of that tip. That's something that you want to wipe off before you go and re-enter into that pocket area. Otherwise, if you kept going and going, you're going to have a hot tip, and we don't want that. This is what the laser periodontal therapy setup looks like. I have my anesthesia, I have my guided biofilm therapy, I have my BioLase Epic X laser, which is a 940 nanometer laser. This is the upper right and lower right when I'm doing laser-assisted periodontal therapy. So I'm going to disclose half the mouth, go through, do my guided biofilm therapy, and do my laser therapy. And then the next week they come back and I'm going to disclose everything. So I can show them, look how virulent this bacteria is. I'm using the triplaque gel on the left-hand side. And I mean, I'm using it everywhere, but on the left-hand side, you can see those three colors, where pink is fairly new biofilm, 24 to 48 hours. Purple is 48 hours or more, and that blue is really acidic and pathogenic. So I'm showing them that and showing them on this right-hand side how quickly that biofilm is building up. So I'm going to go through, disclose everything, use my airflow first, always removing biofilm first, and then removing any hard deposits with my Piezon, going through with my diode laser. And this is what it looks like directly afterwards. You can see how it kind of cut off right at that midline area. Laser therapy, just showing you more pictures of laser therapy as well as using the guided biofilm therapy. Laser-assisted periodontal therapy will also reduce any bleeding, and it will cause that hemostasis to occur. So this is what it looks like before and directly after doing laser therapy. This is using one of the Piezon tools and then going in with lasers, and that's the way it looks right afterwards. There was a very large defect underneath the gum tissue. This is a significant case that had vertical defect on the mesial of number 18, distal of 19. And a lot of the times that's occlusal trauma. So we wanted to go in there and do laser therapy, do your GBT, do your laser therapy, and then doctor came in and did some occlusal adjustments. So they're not just rocking that tooth in there. This is what, this is what laser-assisted periodontal therapy looks like. I'm just going to go into that pocket area. We will get tissue response with doing laser-assisted periodontal therapy, and it is going to interact with that diseased tissue, with that dark pigmentation and that hemoglobin. So I'm going to spend a little bit more time. As soon as I get that coagulum to build up on that, I'm going to take that out and I'm going to wipe it off with a watered gauze. This is laser hemostasis. This is what it looks like before and afterwards. This is a case that I did in January of 2022, and this is what it looks like directly after laser periodontal therapy. And then this is what it looked like in March of 2023. As far as the perio charting, there was a 6 and a 7 millimeter pocket depth, a lot of bleeding. You can see in March that tissue's blanching. There's really no bleeding. And this is what it looked like on the perio chart before and afterwards. So you can see she had class 3 mobility on number 18, class 2 mobility on 19, with a 6 and 7 millimeter pocket depth and bleeding. And when she came back in March, well, she continually came back, but when I did this comparison of the two, March of 2023, there was no mobility, and also no bleeding around those. And they went down to a 4 millimeter pocket depth. You can track that progress as far as the bleeding areas, the pocket depths. We want them to be 10% or lower, as close to 0 as we can get them. She had 3% bleeding sites and 8% in her mouth that were 4 or above. So again, she's right in that range. There's some more graphs for you. This is what the x-ray looked like as far as January 2022 and March of 2023. That bone just kind of filled in around there. We don't get bone growth, but that bone was stimulated, and we did get some fill in of that bone, and those teeth are solid in there. Laser hemostasis, like I said, the laser energy, especially on a diode laser, is absorbed in that hemoglobin, so it can start that facilitation of that hemostasis. Implants are very different than a tooth surface. And we know now that there's 800,000 placements of implants in the US annually. And perio-implant mucositis occurs in approximately 30.7 of these implants. So 63% of our patients have periomucositis. Now, we can treat perio-implant mucositis as a hygienist. But when we move into this perioimplantitis, which occurs in 21% of implants, 34% of our patients, that is beyond our scope of practice. So we need to catch it at this very early phase and do all this preventative treatment. So periomucositis is bleeding on probing. There's visual signs of inflammation. It affects only the gingival tissues around the dental implant. There's no signs of bone loss, and the treatment of the gingival inflammation can reverse these stages. So that's just showing laser bacterial reduction, doing it on a removable, all-on-four removable prosthesis. This is definitely a perio implant case, and it involves the tissue underneath the marginal sulcus there, the gingiva, and also the bone. So it can lead to loss of the implant. So that's something that can be treated by a laser as well, but that's treating it with I don't know why my thing won't go. There we go. So this is treating it with an erbium laser, which you can debride the entire implant. You can go all along that gingival margin and treat it that way. So let's talk a little bit about GBT. What is GBT? It's guided biofilm therapy, and it's a systematic and predictable solution for biofilm management. It's a professional prophylaxis. It's all scientific based, and it's using the synergy of this airflow, perioflow, and Piezon technology, all of those together. And the treatment is performed in the least invasive way, which, like I said, with lasers, it just goes hand in hand. They're both the least invasive ways. And the highest level of comfort, safety, and efficiency. It uses a low abrasive powder. It's an erythritol powder that's only 14 microns. Uses warm water, which is so comfortable, and I can attest to that. And the Piezon instrument is used in localized areas for hard deposits, and it has a no pain technology on that Piezon as well. GBT is an effective means of removing biofilm from the tooth and the implant, and we get better patient compliance, less pain perception, and it can be recommended also for supportive periotherapy following your active periodontal therapy. We can manage around brackets in the sulcus, in intradental areas, in the periodontal pocket, and pits and fissures, around ceramic restorations, around the implants, and around exposed dentin. Whereas before, we just couldn't be as effective and not be aggressive or invasive when we were doing that. This is the Bible of GBT. It's a whole wheel, and you must follow that wheel to do the guided biofilm therapy protocol that is research-based. The research is based on this whole wheel, and you're going to do your infection, your assessment control, and then infection control and assessment. You're going to disclose every patient every time, and like I said, not to tell them where they missed. It's to help motivate them and show them what type of biofilm they have in their mouth and how they can effectively remove that. And then Airflow Max is used on every single patient. There's no real contraindications to using that. PerioFlow is used in those deeper pocket areas, anywhere that you need to access something that is over that 4 millimeters, because the airflow will go up to 4 millimeters. The Piezon PS technology, that dynamic regulation, so it will feel the deposit. When it feels a deposit, it will actually regulate that power on it. And as long as you're using it on the lateral borders, because it is doing a linear motion, you're not going to get that screeching that you hear with a lot of other ultrasonics, and you'll be able to remove that without any discomfort. And then you're going to check the patient, and they're going to run back for their recall. So we're going to make biofilm visible. We're going to remove the biofilm before the calculus. We're going to use the PS instrument only for hard deposits. You no longer have to go through every single tooth every single time. We're not going to over instrument, and you don't need to polish. So in disadvantages of traditional methods, instrumentation can be time consuming, it can be technically demanding, and occasionally uncomfortable for the patient. And we've also seen that over instrumentation every time, everywhere, especially those lower anteriors. I'm going to skip past these. Disclosing, that's the disclosing solution that I use. It will show us 3 different types of a biofilm, or 3 different types of, it'll show us in colors. And these are just some of the cases that I use, and I motivate the patient, show them, hey, this is where that biofilm was hanging out. This is where it bleeds very easily. I just went in with that soft pick in and out a couple of times, and that's where it bled. Air flowing is not air polishing. It's that perfect synergy, again, with the erythritol powder, which is water soluble. And it's that perfect synergy with the airflow prophylaxis master, the airflow, the hand pieces, and the plus powder. And there's a big difference in air flowing and air polishing. So this is the way the airflow max looks like, and it's just really easy to do. You're removing all of that biofilm from all of those surfaces, all the nooks and crannies. And this is about implants. I never knew how to clean implants before. I knew what the protocol was, and I've been doing this for 35 years, so the protocols have changed over the years. But with the airflow, you can be less invasive, and you're not scratching that surface. So these are, again, just some cases. You can also use it on the tongue. I use it at the same setting, right on the tongue, and remove the biofilm off of the tongue. Then their lunch will taste really good. And a perioflow is something that, it's an instrument that goes underneath the gum tissue subgingivally, above that 4 millimeters. This is what the Piezon looks like. It's slimmer than a periodontal probe, so you can get it underneath the gum tissue. You can go up to 9-10 millimeters. And the Piezon technology will implode that calculus rather than taking it and chipping away at it. You just want to let it glide and let it implode that calculus. They have a right and a left, which are one of my favorites, so I use those quite often. And then another one of my favorite instruments is the Piezon PI Max, which is used for implants, around crowns, around veneers, around a prosthesis, around an all-on-4. You can use that underneath this all-on-4 after you've done your airflow. These are just some cases that I'll run through real quick as we get to the top of the hour. This is, like I said, you can show the patient that this is where they're building up. This is half the mouth again, that I did half the mouth on. I had already done that left side, and now we're working on that right side. Lower anterior is really acidic biofilm, really pathogenic biofilm, and trying to get into all those areas on a malalignment. The patient has a really difficult time, so we can show them how they can get to that more effectively, and we can get to that more effectively using our airflow. there's a lot of all-on-4s out there, a lot of implants, and we can be very, very safe, and we don't have to be removing those all-on-4 every time that they come in. This is what one of the cases looked like. An orthodontic case, yes, I'm definitely going to go through, do my airflow, and also use the laser after that. And that's just going to help everything, all that inflammation heal up, and then have the patient come back in a few weeks. But that's really, really acidic. We can use it around prosthesis. We can use it around removable prosthesis. We can use it on dentures. That's something that went through the ultrasonic bath and was brushed. And that's what it came out like when I did my disclosing. So appliances, clear aligners, the last thing you want to do is remove all the biofilm from the mouth and then hand them their clear aligners without anything, without going through and doing airflow, at least checking those areas. Night guards, same thing. Periodontal disease, in conclusion, periodontal disease is a multifactorial inflammatory disease, and it will take a multifactorial approach and therapies by the clinician, and the integration of lasers as an adjunctive therapy with your guided biofilm therapy is least invasive and most effective therapy for controlling biofilm and inflammation. I have some research at the end. I can send anybody these research. If you want to send me your information, I will give you all of the research. And one of my favorite sayings is, if you always do what you've always done, you'll always get what you always got, and by Henry Ford. So let's there's my information. There's my contact information. You can text me, you can call me, you can email me. You can message me. That's my Instagram and my LinkedIn accounts. And that was it.
All right, Lynn,
I have a little bit of time for some questions.
Ooh, great information, Lynn. Thank you so much. And yeah, we have several questions that I wanted to address with you. So the first one, I know you said you can use laser pre or post LBR, but are there any benefits doing one over the other?
There's a couple benefits either way. I think now that I've been disclosing patients, and like I said, I've been doing lasers for 28 years, and I've always done laser bacterial reduction at the end of the appointment. But since I've been disclosing, I realize how much biofilm is there that we cannot see, because biofilm is invisible. So unless we disclose, we cannot see how much they have in there. And I just do not feel that the research backs that up, that in that 5-minute period of time that it can reduce all of that biofilm and all of that bacteria enough to help us out. So, or enough to help the patient out and to reduce those bacteria and the aerosols. But what I do believe in is that it works more on like a photobiomodulation, where it's helping the tissue heal up. We're putting that light energy into there. So I like to remove all the biofilm first. Now, on a very medically compromised patient, I may do it in the beginning and try and reduce some of that bacteria flora, but I'm going to do it at the end definitely as well.
Great. Thank you. Another question, kind of earlier in your presentation, Lynn. When do you reevaluate after a 43-46? 1 month or 3 months?
That's all dependent on the patient. Normally, I won't go 3 months. That's just way too long for that much gingival inflammation. So it's usually 3 to 4 weeks. That's most common. Sometimes it's sometimes it's 4 to 6 weeks, depending on the particular patient and what they show in their medical history and all of that.
Sure. And this participant asked, how much do you charge for laser therapy? I know it depends on the therapy, but can you talk just a little bit about that from your experience in your offices?
I'll talk a little bit about that. I have different offices that I will, recommend different fees. You can either incorporate it into your already existing fees, like on LBR, you could just put it into your existing fees, and that's what you're doing LBR with each and every appointment. If you do it outside of the appointment, outside of the fee for the appointment, it's anywhere from like 35 to 50 would be your range. And then laser periodontal therapy is going to be added to your periodontal therapy or your scaling and root planing fees. And that can be anywhere from $75 to $150 per quadrant or per section of the mouth every time you do that laser periotherapy.
Got it. Thank you. This participant asks, when performing airflow, do you need any assistance?
I do it all by myself, but I have my assistance with my PureVac. You have to use high volume evacuation. But with anything, I mean, with our ultrasonics, we're using high volume evacuation. So it's no different. It is a little bit different technique to be able to remove the excess water and where it's bouncing off the tooth rather than holding it in the vestibule. I love the PureVac, but you have to use some kind of high volume evacuation, whether it be but it has to have an 8 mm opening, and then you have to be holding it within 5 centimeters of that. 5 mm of that area. So you can't be using these external evacuators, because then the aerosols have already come from the mouth, and then they're in the room, and then you're trying to capture everything. So you want it really close to the area.
Got it. This participant is asking about perioflow. So do you have any tips for using perioflow, especially regarding adjusting the tip in the pocket?
So perioflow is used, it has limited uses, but it works great. When it fits, it works great. So around an implant, something that is above that 4 millimeters, something around an implant, something in a furcation, and it is flexible, but you've got to be able to have, fairly edematous tissue to be able to get it in there. Once it fits, it's great, and you use it only in a vertical motion. You don't move it back and forth. And then what else was I going to say? You just don't want to force it anywhere where it won't fit. And if they have really fibrotic tight tissue, you won't be able to get it fit in there. But it does remove biofilm from the whole sulcus when you're using it, because it has water and powder coming out of different ports, so that it'll kind of work in a slurry around that whole area. So I love it for biofilm removal subgingivally.
Great. I'll just pick out one or two more here. This participant's asking about airflow as well. Is the air-water pressure different with the airflow and an air polisher?
Definitely. So it's all regulated on this. An air polisher, it's more chaotic. It just sprays out. So you have no control over the powder and the water, and some of them that are hooked up to the unit, you have no control over the water as well, and how warm it is. So the water is warmed up. You can put the water control on this. It's the perfect synergy of all three of these: the powder, the water, and the air. So if you don't have enough water in there, and this is a water soluble powder that we're using, you have to make that perfect synergy. And if you're not using enough water, or you're using too much powder and not enough water, it's not going to be as effective.
Got it. Thank you for that. And to our audience, I've reviewed a few of the other questions that were remaining, and I think most of them will be related to some of the resources I'm going to talk about here as we close out our session together. So in essence of time, I am going to close us out and talk a little bit about both BioLase education and how you can find more information about EMS. So Lynn, again, thank you. And I will wrap up here if you do want more information about BioLase education, please go to education.biolase.com. And when you go there, you're going to find either the education portion of the menu there at the top of the screen, or resources. Now, resources will take you, we had a couple questions about laser bacterial reduction and laser-assisted periodotherapy. You know, what settings do I set my laser on? What tips do I use? You can find some of this information on this website. Under resources, we have videos you can take a look at. Under education, we have webinar content, we have course content, we have all sorts of information you can find there. So I would encourage you to go there at education.biolase.com. You'll find the Epic Diode Academy there. Of course, that's going to be focused on our diode lasers. And then if you are interested in some of the all-tissue laser technology Lynn mentioned, that's called WaterLase. There is a WaterLase Academy there as well, focused on WaterLase education. Now, as I mentioned at the beginning of our session, very grateful for our co-sponsors of this webinar with Lynn, EMS and Guided Biofilm Therapy. So I'm going to hold on this slide for a second. If you want to scan that QR code real quick, that will take you to their website. I listed it there, ems-dental.com, but also that QR code will take you there for additional information. There was a few questions more about airflow and perio flow. So to answer those questions, please scan this QR code or go to ems-dental.com. And again, thank you to EMS for helping us get Lynn on board for this session. And one or two more things, and then we'll wrap up with CE information. Our next webinar is going to be on June 11th, and it's going to be focused on removing veneers and crowns using an all-tissue laser. So if you are interested in that topic, please join us on the evening of June 11th. And then we have recently put together a summer webinar series. It's a 3-part series with Nick Clausen, and it's going to be focused on kind of the business side of laser dentistry. So how you can optimize your practice growth through laser dentistry. Our first session is going to be on June 27th, with our second on June 11th, and then our third will be on August 1st. These are all going to be a series of webinars, and I would encourage you to join us. You can find this information on our website, biolase.com. Okay, to wrap up, to get your CE, you do get 1 CEU for joining us. You must be officially registered, and attendance will be recorded via Zoom. The most important thing I want our audience to know is that you will receive a survey once we wrap up here, either this evening or tomorrow. You fill out that survey via email, and when you fill out that survey, you will get your CE certificate. So make sure you look for that in your inbox. Again, biolase.com/webinars. That is where you'll be able to find this session, along with all sorts of other webinars that we've posted on there through the years. Now, if I did not get to your question, or you have additional inquiries for our BioLase education staff, feel free to email us at education@biolase.com. So with that, Lynn, thank you so much for your effort putting this great presentation together and for joining us this evening and educating us. Again, thank you to EMS for co-sponsoring this session, and we hope everyone takes care and has a lovely rest of your evening. Thank you.